So the students who are listening, I think it's better for you to have a paper and a pen, because there will be some MCQs and SBS and some SAQs also. And with greetings from Candy, these are, as you know, these are clinical case discussions. So I thought first I'll take you into our unit for a visit. And I know that now you all have been off from boards for some time. But as doctors, actually, we have to work, and maybe as medical students, I think it's time for people to think that whether students' teaching should start. But anyway, you see how we work with new conditions, and irrespective of the category of staff, all get into, I mean, there's no different dress code. There's no white for consultant or blue for others. I mean, we just get wear what we have to protect ourselves. So at the very beginning, so it's very, and I would like to say that this is all teamwork, and we have to respect the other categories of staffs also. We should not think that we are the sort of best out of them or something. It's a teamwork. So I always treat other categories of staff with equal rights. And also a little bit of how you approach patients. It is a good thing that you introduce yourself. But of course, in a ward where there are about 50, 100 patients to see, sometimes it is not practical. And with our culture, there's something called a bit of an implied consent, because the people know that you're coming to talk to them and examine. But as a rule, always if I have got a patient referred from another ward, when I go, always I introduce myself and talk to them. But what it is, it's very important to be very kind to the patients and also to the relations too. And they have a dignity. And especially these are open wards, and there are hardly screens between the beds. So you have to respect them, especially the certain examinations. I don't think we should do in the open ward. We have to get either the screen or to take to a screen bed. These are just few principles I want to talk. But the case discussion is on a patient that we got to one of the casualties a week ago. And the students, you can go through this clinical scenario, and I think the key points here would be that it is a sudden onset and severe pain in the epigastric region. Now, the age is also important, because there are certain pathologies to age. The gender, when it's epigastric pain, I don't think it is of much makes a difference. But if it's a low abdominal pain, the gender is also important. So now this person came to the ward, and actually I just want to ask my first contact doctor, that is my intern, Dr. Charuni. And Charuni, when you saw this patient, what was your first impression as the patient was brought in?
Sir, patient was ill-looking and tachypneic, but he was fully alert, sir.
Okay, so alert means that his airway was okay, but as you said, he was ill and he was tachypneic. So what is the first thing that you did with the patient?
I started him on oxygen by face mask, sir. Good. And examined his respiratory system. It was normal, sir.
All right, so thank you, Charuni. So this is the important thing, that if a person is short of breath, of course his airway is okay, short of breath, you start oxygen and then do a full respiratory system examination quickly, because there may be some life-threatening reason in the chest, but that is normal. And of course, she got the patient fixed to the pulse oximeter. And then the next step is the circulatory assessment, because if the patient is tachypneic, the chest is normal, they very likely the person may be in some form of shock, that's possible. And of course, this says that he is some form of a circulatory impairment, and which may cause a hypoxia. And at some stage, of course, so the fluid resuscitation was started, and at some stage, arterial blood gas assessment is necessary. And just to recapture the physiology behind a person being tachypneic, now this person is tachypneic at rest, so we have to consider all three stimuli for the respiratory system. But if a person is tachypneic only on exertion, then of course it has to be a hypoxia induced by exertion. Now here hypercapnia is unlikely, because this airway is all right. And hypoxia, the first category, whether it's coming from a lung pathology, hypoxic hypoxia, Charuni has excluded by clinical examination. And then now he's in some form of circulatory compromise. So So he is actually suffering from a stagnant hypoxia because there's a tissue hypoxia induced by low perfusion. And of course, anemic hypoxia may be contributing. Maybe he's already anemic, or maybe we still don't know what is the pathology of the patient. Maybe he has bled. Of course, his toxic is unlikely. And acidosis may be there in this patient. Maybe secondary to your circulatory impairment, or maybe the pathology causes acidosis in addition, like a sepsis or maybe a diabetic ketoacidosis. So that's why I said at some stage, arterial blood gas is also important. So now anyway, now he's on oxygen, he's on fluid resuscitation, and these are the pictures we got from his pulse oximeter, and the saturation, which quickly improved with oxygen. But if the oxygenation not improving with oxygen mask, of course, you will have to summon anesthetic support to see whether he will need more forms of respiratory support. But it's very important that you examine the respiratory system and exclude especially pneumothorax before you go into other forms of ventilation, which we have done already. But now he's on fluid resuscitation, so it's a matter of making a diagnosis very quickly. And the diagnosis is most of the time that you have an organ and a pathology. Now in this scenario, the clue to finding the organ is of course that he has a epigastric pain. So now this picture shows the organs in the epigastric region, and Kaushika, you were the senior registrar handling the casualty that day. And what are the organs that comes to your mind when it's epigastric pain, and also the organs in the epigastric region, plus you can get referred pain. So what are the organs that you are considering, Kaushika?
In the epigastric region, sir, I would be considering the stomach, and then the pancreas, gallbladder, even liver pathologies can be considered. And also you should consider the retroperitoneal structures like the aorta, and also there's a portion of abdominal esophagus which can give rise to epigastric pain.
Sure. And also maybe the chest, the heart, and your sometimes pleural pain. So these are the organs that crosses your mind, and then of course we have to think acute pathologies of these organs. So first I'll pose a MCQ for the students, and now this is the scenario, and what are the it's a true false. So out of this you just mark true or false. Pseudocyst of pancreas, acute pancreatitis, bleeding peptic ulcer, myocardial infarction, spontaneous perforation of esophagus. I know in a MCQ you need some time to think and answer, but I'll take you on because there's limited time for the presentation. Now, pseudocyst of the pancreas, the initial presentation is with acute pancreatitis, but usually the pseudocyst presents little later. So the pseudocyst presentation itself is not acute. So I would mark it as false. Acute pancreatitis is true. Bleeding peptic ulcer is an acute presentation, but they come with some manifestation of bleeding, not with pain. So it's a false for this scenario. And other two are also correct. Spontaneous perforation esophagus, most of the time they start with a severe pain, chest and upper epigastric region. Now, later they have a lot of respiratory symptoms because there's a fair amount of mediastinus setting in. So these are the responses. But anyway, we'll take the full differential diagnosis as with the organs Kaushika mentioned, and adding up a acute pathology into these organs. So these are the things that we have to consider. Now, so it's a matter of taking a bit of a history, but now looking at the presentation itself, I don't think it's a biliary colic, because a biliary colic person won't be ill and having a low saturation. And other things all are possible in this scenario. But this patient, when we took the history, so you have to take a focus history, very quick one. And he had a dyspeptic history. He was on NSAIDs, and his epigastric pain suddenly became severe and then became more generalized. So we thought it's more like tubercular peptic ulcer. Acute, he didn't have much of radiation to the back or leaning forward, didn't relieve. But of course, typical acute pancreatitis, these features will be there, but not having this relief with bending forward does not exclude acute pancreatitis. But anyway, our working diagnosis of perforated peptic ulcer. So Sachin, I think you examined this patient, and what were the abdominal findings? And this is a picture when I re-examined this patient, but you can tell what findings were there on abdominal examination.
So the abdomen was distended with generalized tenderness.
Okay, so generalized tenderness is it supports the diagnosis of a perforated peptic ulcer, but as you know, even a hemorrhagic pancreatitis, if there's pancreatic ascites, they can have generalized tenderness. So, did you look into any other physical sign which will tell that it's probably a perforation? So that's what I'm doing.
Hypercapsular liver dullness, which was absent.
Okay, so clinically you establish the diagnosis of a perforated peptic ulcer. And thank you, Sachin. I know that you have to go to the theater, so you can actually log out. Thanks for your contribution, as well as Charul. I think you have a lot of word work. Thanks. And so now we have a working diagnosis of a perforated peptic ulcer. So what is the investigation, the first line investigation that we will do to confirm the diagnosis? And again, I'll put this as a MCQ, or rather SBA, single base answer. And now this is the scenario that this patient had. The person who was on NSAIDs coming with generalized pain and tenderness and absent liver dullness. Now SBA, now this SBA may be given like this: a person has a suspected perforation, and what is your initial investigation to confirm diagnosis? But now this question is at even a better level, because with the scenario, first the student has to make the diagnosis of perforation and then answer. So you may get in whatever form. So I expect the students to go through this and pick up what is your initial investigation, because in a single base answer, all answers will be correct, because there's no point giving one correct and others false. So it's not a true single base. Now all these investigations can pick up a perforation, but you have to think what is your initial investigation. So so you can mark on your paper what is your first investigation that you will do to confirm the diagnosis. So what we did was erect chest X-ray, and we have got an expert in radiology to comment. And Badra, now what do you think? Now these are again slides coming from you. What do you think the initial investigations, was our choice correct to get an erect chest X-ray to find the pneumoperitoneum?
Yes, Kalkati, erect chest X-ray is the best. If the patient's condition actually permits, some patients are very ill, they can't pose for a erect chest X-ray. Otherwise, erect chest X-ray is the best, because what we are expecting is the gas under the diaphragm. So even if 1 ml of free gas, you can see it on the erect chest X-ray 85% of the time. So that is considered the first line investigation. But if the patient is very ill, actually left lateral decubitus is considered. I mean, you can do it. It has a very high sensitivity, but there are a few problems actually practically when we are doing it. The technicality, because you need to put the patient on the left lateral decubitus position, and you may not get, I mean, patient may struggle, or the radiographer, you have to keep the cassette. So there are a few technical points. So even if the left lateral decubitus has a very high sensitivity, practically this may be not that sort of feasible, but I mean, that is a second option if the patient is ill.
Okay, but now you say with even 1 ml you have 85% sensitivity, but most of the time when our patients present, they have a lot of gas. So in that case, does this 85% go to even a higher level?
Of course, then you will get about a 5 centimeter or 10 centimeter column of free gas under the diaphragm. So
yeah,
obviously, I mean, it will be higher. I mean,
sure, that's right. Because now I've been working as a surgeon for more 30 years, but all these perforations, when you clinical diagnose the erect chest X-rays, is positive. Now, Badra, now abdominal erect X-ray, why is the sensitivity low? Now, if you get the patient erect in abdominal X-ray, what is the reason why sensitivity is low?
I think the diaphragm is the key place that we are looking at. So we may not catch the diaphragm so on the erect X-ray, because the height of the patient matters, the cassette size. So sometimes you may not catch it. So that may be the reason. And supine X-ray, actually, we do quite often, because patients, when the patient is ill, and you need sort of expertise to diagnose perforation in supine abdominal X-ray, not like the erect chest X-ray. You just see free gas under the diaphragm.
What
Supine
do you mean
X-ray.
is even a surgeon can diagnose on the erect chest, but maybe not on the supine X-ray? Sorry.
So that is the reason why there's low sensitivity. So in a sort of acute setting like a casualty night, erect chest X-ray would be the best.
Sure, thanks, Bhadra. Now, Bhadra, in a lot of things in medicine, we have what are called gold standards, again, against which we actually assess the other things. So in a pneumoperitoneum, what now so for the students, the take-home message is the initial investigations is to get an erect chest X-ray. But if there's some problem of getting the patient standing up, get the left lateral decubitus. Now, Bhadra, what is the gold standard in a pneumoperitoneum?
Actually, the CET, because CET will show you even if there's very little, and because it's a cross-sectional image, you can look for it over the liver. So you are not going to miss it on the CT. So it is considered the gold standard.
And but if you with the contrast, you may see, you may see the leak from the, whether it's a stomach leaking from the stomach or duodenum, is it?
Yes, but I mean, usually we do just NCCT. I mean, if we want to confirm the diagnosis of perforation, of course, if you are looking at the site of leak, we may give oral contrast.
All right. So what you mean by gold standard is a non-contrast CT.
Yes, non-contrast.
Sure. Thanks, Bhadra. And also just one point, Bhadra. Now most of these perforations we see coming from the community are perforations of the peritoneal cavity, but sometimes we get retroperitoneal perforation. Sometimes with trauma, the duodenum can have retroperitoneal perforation, and also now the time of ERCP. With the ERCP, very rarely we get perforations, and they are like nearly they are retroperitoneal perforations, and retroperitoneal perforation, I mean, there won't be generalized tenderness. Generally, we on percussion, the liver dullness is there. In that up situation, even your chest X-ray erect, what do you think? It could miss, isn't it?
Definitely. I think in that scenario, if you are suspecting retroperitoneal perforation, best thing is to do a CT scan, because
so that would be a contrast.
Yeah, but I mean, supine abdominal X-ray also will show there are certain changes, but you need expert to read it because there are a lot of, abdominal X-ray, you get a lot of gas shadows. So out of all the gas shadows, to differentiate from retroperitoneal AR to intraperitoneal AR or intra-viscous, like gas within the sort of bowel, you need a little bit of expertise. So I think best thing is to do a CT scan, because anyone can see gas where you want to see.
Sure. Okay. Bhadra, so actually, I also thank these slides are also your intellectual property. You give me the slides, and put the next slide again, what you have sent to me. If you don't mind, you can comment on these X-rays, Bhadra.
Yes, the first X-ray on your left-hand side is the erect chest X-ray with a lot of gas under the diaphragm. You can see the diaphragm as a soft tissue shadow and translucent shadow underneath between the diaphragm and the liver. You can see. I can use my mouse. So this is pneumoperitoneum. You can see it bilaterally. And sometimes it may be difficult with the gastric air bubble, but in this case, you can see the gastric air bubble separately. And this is a case, very little gas. So even with a very little gas, you see it. Actually, there is gas on this side also, but we are not too sure, because on the left side, gastric air bubble and the splenic flexure, both can be seen in a normal individual. So it is easier to see it if it is there on the right side, because that is seen against the liver shadow. So this is a supine X-ray. Actually, there are some arrows. This is some hepatic air collection, maybe around the falciform ligament. And this is the sign that we look for. This is the Wriggler's sign, where you tend to see the both sides of the bowel wall. Usually we see the inner wall, because gas and the soft tissue density of the inner wall is contrasted. So you see it when there's gas outside the bowel wall, bowel lumen, intraperitoneal air, you tend to see both sides of the bowel wall. So this is a great person who described this Wriggler So it is the sign that we look for in a supine X-ray. Actually, it is seen in most of the instances, but you need a little bit of expertise. Once you develop that skill, you will see that. So this case again, subhepatic collection. You can see it's a liver and there's a very large collection and it's trying to go into the sort of around the falciform ligament here. So there are so many places that you can see here. And this is the typical cross-table or left lateral decubitus. You know the reason why we call it left lateral decubitus. Patient is lying on the left side, so that you will not have a problem of mistaking it for the gastric bubble. You allow the patient to wait in this position for about 5 minutes so that the air will go up, and you will see the air translucency against the soft tissue density liver shadow. As you can see here, all the way from the diaphragm to the RIF, you can see the gas translucency. So this is the pneumoperitoneum that you see clearly in the lateral decubitus field.
So thank you very much, Bhadra, for your expert opinion on this. I'm sure there's a lot of learning material for the students. Thank you, Bhadra, once again.
You're welcome.
Okay, so this person now has a confirmed perforation. So he needs a laparotomy, and the students, you can actually quickly list how would you prepare this patient for surgery. I'll just give a couple of seconds. You can start writing and also watch my slide. So I think we have to start on broad-spectrum antibiotic. He needs fluid resuscitation, and better to start a proton pump inhibitor IV. Kaushika, now even our first video clip showed that there's an NG tube. Why would you like to use an NG tube in this situation?
It will decompress the stomach and it will prevent the, sometimes it will drain the stomach and it will decompress, so it will help to reduce the decontamination.
Even the stomach is leaking out to the peritoneal cavity, still there's some paralysis of the stomach. So you usually see a lot of fluid there. So you have to get a catheter. And then of course dispatch some preoperative investigations, group and cross match, and better to get the anesthetist to see before taking that into the theater, and perhaps reserve an ICU bed because this patient is a bit of a shock on presentation. And this is very important: consent from the patient and also informed relations. Now actually we always make the mistake that we think the relation should consent because the consent should come from the patient, but always you can inform the relations of the condition of the patient. But of course if they object, that's a different issue, but sometimes they are on a bit of a psychological issue when you ask to sign for the surgery for a relation, because it's a very hard decision for them. So always I think the consent should be from the patient unless it's a child. So but anyway, now, so we took the patient to the theater, and I can see Sachini closing the abdomen. Maybe Kaushika, you went for a cup of tea after doing the surgery. But what were your findings and what did you do?
Sorry, sir, I couldn't get the question.
Yeah, now this Sachin is closing the abdomen, and what are the findings at the surgery? There was a perforated peptic ulcer.
There was a perforated peptic ulcer with the contamination of the peritoneal cavity. So we did a thorough peritoneal lavage to reduce the contamination of the peritoneal cavity, and then we sutured the ulcer. Before suturing, we took a edge of the ulcer for biopsy. And then we sutured it and we reinforced it with a nomental patch.
Well, why did you biopsy, Kaushina? This is a gastric ulcer. Why did you biopsy? Yeah, I think there's some problem, but anyway, so with the stomach, sometimes it may be a malignant ulcer, and also you can check for H-pylori if you want. Now, a short essay question for the students about the post-operative care. You can just quickly list what you do post-operatively. And these are things that I would do for a patient. Monitoring. Well, feeding orally, I generally would like to wait for a while. But of course, when you're in a house, it's better to ask a consultant's opinion before you start on this type of patient's oral feeding. And IV antibiotics have to be continued. And analgesics, a temperate chart, So these are things that you would do post-operatively. Now, this is the temperature chart of this patient. We see some fever spikes. When you look at the classification of surgery according to the risk of post-operative infection, we have this clean surgery where you have just only the skin commensals get breached, and then the clean contaminated, where you open a hollow viscous and some stage, but with very good control. There's no gross spillage. So these type of surgeries, the first few days you will not get any fever. If you get a fever spike on the first day, this type of surgery, it is usually due to atelectasis. But then now contaminated is that says you're operating on a acute cholecystitis in contrast to elective cholecystectomy. The gallbladder is already inflamed. So there is now the organism has already started invading the body, and of course what we dealt here, the perforated peptic ulcer, where it is already contaminated, dirty, and of course it may be not, there's not much of time for an infection sort of to but of course it's a virulent form of contamination of the peritoneal cavity. But now in the last two categories, first day's fever, it may be due to, because already you have an infecting thing. So this, of course, you may have some fever, but of course with your antibiotic it should go down, which happened, it settled, but then again after about the 5th day, we started getting fever spike. So it means that some infection is setting up. So I just want the students to attempt this question. Now in this type of thing, after on the 5th day, if you get fever spikes, what are the possible sites of infection, and also are there any non-infective reasons for a post-op fever? So you can just list the possible sites for post-op fever and compare with what I'm presenting. So it may be a wound infection, it may be a respiratory tract infection, a urinary tract infection is possible. All these excess sites are possible. And also one main worry is whether there's infection at the site of the surgery. So here it is the intra-abdominal. It depends on, say, if it's a neurosurgery, there's an intracerebral infection. So, and also here it's intra-abdominal. And of course, the non-infective one, leave it in, but it won't cause very high fever spike, but it may have a low-grade fever. So now with this type of thing, with all these possibilities to find the source of infection, you take a quick history. So you ask a brief thing like whether they have a cough, productive sputum, any pleuritic chest pain, and also any undue pain at the wound site, and you can inspect the wound and see whether there's a wound infection. But with the worst thing is, of course, there is an intra-abdominal infection where the patient will be quite ill, and there will be sort of distension, and you will feel a lot of tenderness. And of course, this patient had a minor wound infection, but of course, sometimes you get intra-abdominal abscesses forming. So in which case you would like to confirm it with some investigation. And Jeevani, now here I have two images, one ultrasound and a CT. Now, what do you recommend as the initial investigation when we suspect intra-abdominal abscess? Now, in this case, gastric, it's like to be a subphrenic abscess. What is your recommended initial investigation?
Recommend initially is ultrasound because it's freely available. There's no ionizing radiation, and actually you can take the machine to the bedside and do even if patient is acutely ill without bringing the patient to the department of radiology. So initially we can assess and diagnose the abscess, and later we can get a clear picture. You can go for a CT that actually it has to be a contrast enhanced CT, and then you can get an idea about the volume and other things. X-ray doesn't play a major role, but if you take an X-ray, incidentally, you might see the elevation of a diaphragm in this case.
Okay, Jeevani, just few questions. So first line investigation, you think it's an ultrasound. Now, if ultrasound confirm the diagnosis, then is a CT necessary to either diagnose or to treat? No, I mean, further clarification, is it necessary?
No, it's not really necessary, this kind of thing. Only thing, if you want to see the extent, sometimes in the ultrasound, it's difficult to see the extent because of the airfield bowel loop.
Sure.
That is the limitation of the ultrasound. This in that case, and the retroperitoneal extension and all, you can't see. Not in the particular case. That case, you have to do a CT and confirm the extension and the volume. Another thing, you can see the enhancement of the wall. Sometimes there are some sterile collections are there, and infected collections are also there. So that
Yeah,
can
even now, if you are
differentiate. But
thinking to do a ultrasound, a guided drainage, still your ultrasound is adequate.
yes, even guided drainage you can do with the ultrasound.
Sure. And even now, say, supposing now, if I'm worried whether the perforated thing has again reopened when there's a leak, in that case, a CT will be helpful, isn't it?
Yes, CT, if you want to see if there's any leak from the anastomotic side, better do either you can do a upper J contrast study without
Sure.
doing a CT. Just do a few X-rays you can give contrast orally and take few X-rays or do the fluoroscopically you can screen, or otherwise give oral contrast and do some CTs. Even you can do a non-contrast and followed by a contrast CT.
Sure, thanks, Yoni. And this, of course, now you said that now the last question you answered. If there are no facilities, the X-ray may show. Now X-rays, generally, now there's something called fluid gas level. Is there something like that, or for abscesses and X-rays?
Yes, you can get, if there's sometimes you can get fluid level as well, because sometimes there are density difference of the fluid. The more dense fluid will accumulate in the dependent part. Then in the ultrasound you can see fluid level, but in the X-ray you can see air fluid level. If there's gas forming organisms are there in the collection, you can see the air fluid level. Or the collection is communication with the gas field viscous, then also you can get the air fluid level. Usually you get air fluid level in the erect X-rays.
Okay, Jivani. So thank you very much, Jivani, for your support. So we'll just keep moving few questions on perforations for the students again regarding peptic ulcer perforation. Jivani, I'll need your support a little later on the next case also.
Sure, sir, sure.
So now you can mark true, false for them. Yeah, so now a peptic ulcer perforation doesn't cause a massive upper GI bleeding. Actually, when you open the peritoneal cavity, you don't see blood because actually the perforation, there is some ischemia on that, so that's why they perforate. And also to diagnose, you don't use endoscopy. And then, of course, as Kaushik explained, in a gastric ulcer, you have to take a biopsy. And these things are not done, the vagotomy is not done now at laparotomy in case of the surgery. And Helicobacter pylori needs exclusion because if the Helicobacter is there, you have to treat that. Okay. So these are the answers for them. Now I'll get on to the next presentation on acute pancreatitis. Now, this also can present with acute severe upper abdominal pain, and the patient typically will have relief with bending forwards, and it will radiate to the back. But as I said earlier, absence of them may not exclude it. And of course, with the history, there are other things that we have to evaluate. Other than making the diagnosis, you have to do a good systemic review because it's a multi-systemic disease. And also, it's very important to identify etiology because so that it doesn't keep on recurring. Examination, again, you have to do a full examination of the patient, the cardiovascular risk because all may be compromised. And abdominal, you can have a distension of the abdomen, and there will be tenderness in the epigastric region, and if there's a pancreatic ascites, there may be generalized tenderness. Now, these physical signs we don't see very often. They are seen in white skin people, and also if it's a severe attack with retroperitoneal bleeding, and you can see some bruising around the umbilicus, which is called the Cullen sign, and on the flanks, which is the Gray Turner sign. Now, Kaushika, what would you do? What will be your initial investigation to confirm the diagnosis when you suspect a pancreatitis?
We would do a serum amylase.
All right. Okay. Now, about how it has to be raised about 3 times generally. Now, if the presentation is a little later, what do you think about this?
Then we would go for serum lipase because amylase has a short half-life, and the amylase level can be normal when it comes when the patient presents at a later stage.
Sure. So now with these you can diagnose, but now I'm listing some organ function tests and blood counts, CRP, blood sugar. Do you think all these are necessary, Kaushik, in acute pancreatitis?
Yes, sir, these are necessary because pancreatitis can range from a mild attack to a severe attack. So in the initial stage, it is important to identify whether it's a mild pancreatitis or severe pancreatitis. So these tests are included in most of the scoring systems that we have to grade pancreatitis. So all these tests are necessary to identify a mild attack from a severe attack. And CRP values also, they say that early in the when there's a higher CRP at the early stage, it has a poor prognosis and it shows severe attack.
Sure. So when you classify into this either severe, mild, moderate, or severe, your management also may be influenced by that, and also especially whether you're going to manage in the ward or whether in the HTO, ISO, that also comes. Now, Jeevani, just about imaging in acute pancreatitis, and I think these are ultrasound and a CT. Now, what do you think about the sensitivity of ultrasound versus CT in imaging acute pancreatitis?
Yes, CT is the best imaging imaging modality of choice because it's highly sensitive. Right, it ranges about 65 to 90% like the sensitivity, but the ultrasound is about around 50% the sensitivities. But still, we are doing ultrasound as it is easily available, and I said it is available in the most hospital, and you can do it quickly. But only thing the sensitivity is less. Only thing you can do, you can see if you can find the findings of acute pancreatitis, then it's okay. But sometimes you can't exclude by doing ultrasound. There is no pancreatitis. Still, if the clinical suspicion is there, you have to go for a CT.
Okay,
Like,
so it's the most sensitive data. But we do is generally now all cases we do a ultrasound, especially because we have to rule out biliary calculi. In a mild attack, we may just wait with the ultrasound. But if it's either moderate or severe, or patient going to complications, of course, definitely we'll ask for a CT. What do you think about MRI and MRCP in acute pancreatitis, Jeevani?
Yeah, now sometimes actually ideally you have to do a contrast enhanced CT because a non-contrast CT you can only see the like you can get a rough idea edematous pancreas, small pancreatic fluid collections and the hemorrhages. To see the severity and the degree of pancreatitis, you have to do the contrast CT because that will show the enhancing and non-enhancing areas of the pancreas. So sometimes some patients having allergic reaction to severe allergic reaction to the contrast, and sometimes the patients are having renal insufficiency. Those kind of patients you can do MRI. Oh. And then the MRCP is ideal to assess the biliary tree and the pancreatic duct system. So if there's any collection communicating with the, you're suspecting collection communication with the pancreatic duct, then the MRCP is ideal.
So that means in a pseudocyst, it may be of value sometimes. In a pseudocyst of the pancreas. Okay, Jody. Anyway, thank you. I think there's some problem with my internet. Anyway, thanks a lot. And then getting on to the treatment. So, of course, you have to look at resuscitation of these patients. Monitoring is important. And also pain relief is important. Antibiotics, of course, there's no sort of there's no indication to start everybody on antibiotics. Only if you get some infection, setting up, you do this. Then fluid and nutrition. Now, earlier there was a concept of gut resting in acute pancreatitis, but now we don't think like that. If the patient is not nauseated, not vomiting, you can actually start on clear fluids. But it depends, of course. And also NG tube, generally not necessary, but if a person is vomiting a lot, just to comfort him, you may insert an NG tube. In some cases, you have interventions. Actually, now all this, the treatment is on stabilizing the patient, and also they can have complications, generalized and localized. So when there are complications, only most of the interventions are necessary. I'll just run quickly on these complications, systemic, and then there are local complications. Now, systemic complications are what are more common in the first week. And these are things that your monitoring and fluids are important, and you may need various forms of respiratory support, renal support, if it happens. And it's very important to keep an eye on their metabolic things. These, of course, all will need some supportive treatment. And then looking at local complications usually develop after the first week. Acute fluid collection may start early. If there's a pancreatic ascites, sometimes they need some form of a drainage, then the person may feel better. Then this pancreatic necrosis setting in, it gets worse if it's infected or forms an abscess. Now here is a situation you need a CT and also may need some form of surgical drainage. So surgery in pancreatitis has to be very selective, because if you can wait without operating, that's the best. Pseudocyst forms much later. I'll not go into discussion because there's no time on this. Pleural effusions also may need drainage. Okay, so these are some things. Now, I said, so now this is a MCQ regarding investigations in acute pancreatitis for students. So I think we have already discussed this in the presentation. You can compare your answers and see, because normal amylase you can't exclude. An abdominal X-ray won't be diagnostic. There may be some other indirect evidence. And here is an ultrasound where there are multiple stones in the gallbladder. And these are some MCQs regarding acute pancreatitis due to biliary calculi. Yeah, so now the typical ones to cause pancreatitis are small stones, small multiple. Generally, when they are less than 3 millimeter, only the risk is high because they can easily escape the cystic duct. And because they are small, they usually go into the duodenum. So to see obstructive jaundice in this situation is very unlikely. So therefore, ERCP is not necessary in all cases acute pancreatitis due to biliary calculi, where you do ERCP only selectively. And because there are stones, you have to do a cholecystectomy, but this you do once a person's acute pancreatitis settle, not within the acute phase of 48 to 72 hours. It is an acute pancreatitis I'm talking. And also once the pancreatitis settle, you don't wait an interval of 6 to 8 weeks, because another stone can migrate and you can get another severe acute pancreatitis. So in acute pancreatitis, don't get this confused with acute cholecystitis and surgery. This is acute pancreatitis due to biliary calculi. The best timing is as soon as the acute pancreatitis settle, when the patient is fit, without waiting for a long time to do the surgery. So this is what the answer I gave, and then a short video because surgery usually not everybody, but of course some end up in surgery. So I thought I'll take you into a surgical clip, also revising some anatomical landmarks and how we do a cholecystectomy. I'm sure you have seen a cholecystectomy being done, and with the diathermy dissection, we dissect the cystic duct and the cystic artery, clip them, divide, and then remove the gallbladder. So that's a dissection going on. So critical view of safety is that we identify the cystic duct and cystic artery without any doubt. So this will prevent any damage to the common bile duct. We have to be particularly sure about the anatomy before we clip and divide the structures. There should be no doubt that it's a cystic duct or that it's a cystic artery. Okay, so that's the end. And anyway, thank you very much for this listening, and also for all who contributed to the discussion. And if you have the students have any clarifications on any matter, you can actually send me a mail. And also just another reminder that there are about 20 or maybe about 20 to 30 clinical case discussions on the YouTube. So anybody interested can go through them. Anyway, thank you very much once again for for the support, Kamshika.
Thank you, sir.